We are here with Dr. Simi Silver. Super excited. I know I've been gone for a couple of Thursdays, so I'm excited to be back with you guys. I'm going to go ahead and introduce our speaker. Dr. Simi Silver received, oh my goodness, I have not been recorded. You guys, hold on, record. Sorry. All right, I'll start over. Welcome, everybody, if you're watching the recorded version. Dr. Simi Silver received her Doctor of Dental Surgery from the University of Toronto in 1996. She has experience and proficiency in many dental treatments, including cosmetic, preventive, root canal treatments, prosthodontic, dentures and crowns, implants, whitening, and night and sports guards. Dr. Silver has 27 years of experience providing phase 1 orthodontics, 10 years of experience with clear aligner therapy, and 5 years of experience releasing tongue and lip ties in patients beginning in infancy through adulthood. She also evaluates and treats children with improper craniofacial growth and development, incorporating orofacial myofunctional therapy together with airway and sleep dentistry management. Dr. Silver maintains a professional membership with the, how do you say that? Ottawa
I have
Dental
no idea what
Society.
you're reading.
Ontario Dental Association and Ottawa Women's Dentist Study Club. She is also an active member of the Argyle Implant Study Club.
Oh, that's so old. No. But
Oh
anyway.
my goodness. Okay, Dr. Silver has her own practice. Is this one correct? It's Silver Dental Care Center in
Yes.
Ottawa, Canada. Well, we just got to update a few things. Please let us know what we missed. Introduce yourself. And the topic today is from orthodontics to sleep, a screening approach for healthcare teams. So welcome to Area Circle.
My exciting pleasure. I was going to mention too that my daughter right now is in Brazil. So there you go. Yeah. And having the time of her life, that's for sure. So yeah. So on that cheery note, I do have 5 children. She's one of them. And I live in Ottawa. I'm first and foremost a clinician. So I know a lot of times you have these researchers and those are the guys that I quote here, right? So I'm here to share with you basically what you can do in your clinic to find these and how right now I don't do any general dentistry anymore, just focused on airway. I've got the AADSM qualification and planning to write the board exam for the ABDSM. So you can all send me good wishes for that. So I'm here to share with you some basic stuff so that you can try and get unconfused, because I find a lot of people, even in my own clinic, my hygienist is like, what is she talking about? My associate, can you do that again? So I figured it was important to make this for my own staff and team and for locally. And then I thought, hey, if I'm allowing people to understand it, let's try and explain it to everybody. So let me start with how I got here, because although I was doing these phase 1 ortho, I had no idea what I was doing for all these little people. And basically I did that because of my own experiences and continued to do it, started learning about tongue tie, and here I am. In all the 20 years before that, though, it was like that aha moment where I just went, oh, this makes sense. Everything I've been doing and everything I'm trying to do, all the TMJ problems, all the crowding problems, all the breaking, bruxing, all those problems just made sense. So with everything I'm doing now, it's a totally different career. And I have to, first of all, thank Renata greatly for providing me this opportunity, for providing this first-rate education that I've had throughout COVID without having to leave my home. And, you know, I am still waiting for that t-shirt though. And I'd also like to recognize another organization that I'm sure is also near and dear to your heart, Renata, which is the AAPMD. And they are, okay, let's find out how this goes to the next slide. There we go. They are a group of, it's Physiological Medicine and Dentistry is the name of the group. And they are international, and they have also got people doing this kind of thing. So I'm kind of doing this as well at their motivation, I guess, you know, to say, hey, stand up and teach people how to do this and what it is about, right? They include dentists, there's sleep physicians, there's physical therapists, there's hygienists, and even some dentists. They also are very concerned about children, and they've got this separate organization if you're interested in looking into that. But the main point I want to point out here is that malocclusion and airway dysfunction are what they're focused on, right? So these are really critical issues that, in fact, the CDC has told us that sleep apnea, which is a breathing problem, is an epidemic. And we were taught, I don't know about you, but I was taught in dental school about our teeth. Eating, they grind, maybe a little bit about speech, maybe a little bit about sleep apnea. You know, there's these sleep appliances. That was about it, right? So this is what I'm here to tell you about, right? That basically, by the end of this discussion, I'm hoping that you will feel you know better so you can do better. So please let me know if you're totally confused by the end of the night or if it's crystal clear. Because that's, again, the challenge that we're trying to focus on here. So our goals today are going to be talking, as we did already, about the organization. And I'll have those resources posted at the end again. We're going to discuss what exactly is the airway, what is our role, why screening is important, and how we got here. And if you do have questions in the middle, you can feel free, if it's like something that pertains right away, just stop me. So, and then I will figure out how to get to the next slide here. Okay.
I think just press the enter, yeah, or the space.
I don't know,
bar.
I've got this little bitty MacBook and then I have my notes over here, right?
Okay, go for it. We're good.
It worked. So this is just a little part. You can look this up, or I'm sure that Renata has it somewhere on the Airway Circle resources. And yes, as a matter of fact, last week, I would highly recommend you sign up with her. Last week, I got a patient from Airway Circle, and I'm like miles away up here in Canada. So the ADA in 2017 just quietly mandated their members to screen for sleep-related breathing disorders. What's a sleep-related breathing disorder? At the time, that was my question. I was like, huh? What does that mean? We chew, we talk, oh, we breathe? I think this is the most important slide in the whole presentation because it mandates us as dentists, right? And then that carries out throughout all of the other, whether you're a hygienist, you're part of the team that is looking at people, and you're looking at mouths all the time. Who else looks at mouths as much as we do, right? And this second part here is going to highlight to you that this is a part of general health. It gives you clues how to screen. And the mandate is specific to sleep-related breathing disorders, right? So breathing in general is something that I also manage, as well as I know myofunctional therapy does that too. But it's important to remember that this particular mandate is about sleep-related breathing disorders like sleep apnea, snoring, these kind of things, right? So why do we care? What do we need to know about this for, right? What is meant by an airway issue? What is meant by airway? Right? What's the role of the dental team? Why are you here listening to me at all? Right? So if you do have airway issues, you know, you understand. I have airway issues. I've had them my whole life. I won't go into the details, but let's just say it really is something I'm very passionate about, because when you can help somebody as a child, I also help adults, but it's life-changing on both ends. But it's particularly life-changing if you start young, so that you prevent a lot of these problems. Much harder to fix when you're older. What are these risks, and what is it important got to do with dentistry? Well, for one thing, if you do a lot of fabulous dentistry, like implants and major reconstructive, major makeovers, you'll find that if you have somebody who's grinding in their sleep, which is related to sleep-related breathing disorders, as we'll talk about later, you're definitely going to be frustrated and wonder what you can do. Is it your dentistry? No, it's not. So what is sleep for altogether? Sleep isn't just like, we're not like cars. We don't just shut ourselves off and rest for a while, cool off, and get up. There's a ton of processes that are going on for brain development, for maintenance of your immune system, lymphatic system, things we are only starting to understand. It's also very important for behavior and for mood. 1 in 4 children who have been diagnosed with ADHD actually have sleep-related breathing disorder, probably sleep apnea. And this is kids that I see every day in my clinic. So I have the general practice, I have an associate, and she couldn't believe when I started training her what to look for, how many kids were affected. And of course, it's also sorry, my dog is whining there. The problem is that it's also my own staff whose kids are affected. And so it's not a problem. It's amazing that they got aware and were able to help them and treat them. And they're just like, their minds are blown and so excited, of course, as well, to be able to help their kids. So we're screening to reduce the risk of all of these issues, risk of depression, risk of heart attack, risk of Alzheimer's, which I think is a newer study that came out where we learned that all of this stuff that goes on at night, actually, if you don't have good REM sleep, which is in particular when those apneic or stop breathing times occur. On cue, my dog is coughing. So, so that is actually, instead of gardening and pruning back all your little neurons at night during REM sleep, you're getting beta amyloid bodies, which are why you might end up with Alzheimer's if you have sleep apnea. So my goal here is just to educate and explain. Okay, so what is the airway? Well, like you see on the slide there, starts at the nostrils, goes down to the lungs. We're focused on the upper airway. And in particular, what we want to think about is that the nasal cavity to the epiglottis and then the trachea down below, that's all rigid, right? But in between is the problem, right? So you got all these floppy bits of stuff made of all kinds of different body parts, our tongue, our tonsils. The oropharynx is not an actual structure. It's made up of different things, right? And it's that floppy tube collapsing that causes us to snore or even stop breathing. Try to show you it's not so simple, just as a reminder. Okay. And this is my favorite visual for this. So it's a little misleading because obviously we want everybody to be breathing, you know, closed mouth, breathe through your nose. But I love this visual because I tell people you don't want a straw to breathe through. You want a garden hose. When we talk about why we need to screen, we also have our own personal stories. And this is a more specific explanation, like directed at each system that can be affected. And this is just some key words that might jump out at you. Basically, though, when you do have sleep apnea and your breathing is not effective at night, so you're stopping to breathe, right? That tube is just closing right down. Your brain's going, breathe, 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 you're up. So all night long, this goes on. Now, some people think they actually wake right up and they think it's because they have to go to the bathroom. When in fact, if you knew how many times per minute or per hour some people stop breathing, you would be shocked. And then you have to consider that whole little episode I demonstrated for you. You're getting a fight or flight response all night long. So that's going to cause havoc on all kinds of systems. Your heart rate goes up, your blood pressure is going up. You're going to have a higher risk of heart attack, higher risk of stroke. And on top of that now, besides the higher risk of Alzheimer's, you're also extremely tired all day. So you have a higher risk of car accidents, depression. You can have decreased sexual function, and you have work-related injuries. There's a whole host of problems. And for kids, it's a little different because they actually end up showing hyperactivity, right? So they get overtired, right? And again, all of these that we discussed there. And again, now we'll go back to how to actually look for things. So I'm going to start off by you're just welcoming your patient in the waiting room. Here they are, right? What are we looking for? We're looking for mouth breathing mostly, right? So all these other things go with that, because if you are a mouth breather, your whole face ends up getting shaped by that, right? We have to just remember to look for it, right? So the mouth breathing is going to also contribute to having a retrognathic mandible. And I don't have that, but my whole thing is retrognathic for a different reason. So you have to look for this. Look for lips that don't come together. Look for the retrognathic mandible. Look for the open mouth. Look for the forward head posture, okay? Especially in the kids. As soon as you see this, look at their tonsils. Check back down their throat and see how they're doing. We'll get to that too. A little more about nasal breathing, just because here we are in airway circle, and this is like mind blowing. I'm a total mouth breather because of my issues. And, you know, maybe if I would have had optimal breathing from the start as a child, I would have been, you know, as accomplished as Dr. Yoon. Who knows? But in the meantime, at least I'm doing this and making a change in a lot of people's lives, because as soon as you can correct this and treat people to, especially again, the children, to be able to close their mouth and breathe through their nose, they sleep so much better and they feel better and they function better. They do better at school. Everything changes, right? So again, you can see in the pictures there, some of the things you can look for. I'm trying to pick out just a few key things. So if we just say, okay, there's mouth breathing, great. Retrognathic mandible, great. All these other things, add them to that, but don't focus on too many things because it's going to be overwhelming, right? But I wanted to throw this in so that, again, you get a little more of the details. And I wish I knew which number slide this was so that I could figure that out. Okay. We're good. So after the waiting room, what are you checking? Medical history. I know that's what you were thinking, right? Well, these are the big four, right? So when you have high blood pressure, like you haven't even looked at them. You just look at the medical history. Oh, this patient has all the things, right? Comorbidities are typical. Diabetes, high blood pressure, and of course, if their BMI is very high, that's the typical stuff that occurs. And it's like a catch-22 because the more you don't sleep well, the harder it is to take off the weight because of hormonal issues, actually. So it's very important to check for all of these kind of things. This is not a one size fits all, however. Women, in fact, come up much differently. Often I have sleep apnea. I've had sleep apnea for over 20 years, but it wasn't properly diagnosed until a couple of years ago. I don't have that big neck. I'm not a big person. So you have to be careful to look for these other signs and symptoms. Do you wake up with headaches, right? Do you know, have you got a dry mouth when you get up? Are you snoring? Snoring, by the way, in any age, that one question alone, I feel, should be on everybody's medical history. As soon as you meet a new patient, give them that medical history, right? You should be asking if they snore. Kids, babies should not snore.
9.
So
Where?
the other things that we've talked about already, right? High blood pressure, heart disease, diabetes, the morning headaches, dry mouth, you can ask those as well. And of course, reflux can be related too. Very common to be a problem. Let's move on here. And when you're looking for kids, again, hyperactivity, right? Yes, they can be tired, but usually they're just not in good spirits. They usually snore. They will often bedwet past the age of 10. So when you go in to do the clinical exam, right? So we've done waiting room, medical history, and now we're finally getting to the real meat and potatoes, right? The clinical exam. Here's some things you can look for. We talk about mouth breathing again. Talk about also grinding. And then we get into the grinding and the small arches and even a cross bite. The scallop tongue showing that there's not enough room in the mouth for the tongue. That tongue then could be falling back and causing the sleep apnea, or at least the snoring. This is also, to be clear, not something that dentists or any of us, unless you're a sleep doctor, should be diagnosing. So we call it sleep-related breathing disorders, and we tell them, go see your doctor. First line of treatment, if they have one. Here, it's very hard to get one these days. So the other thing you're going to start doing, because after you finish this, you're going to listening to me, you're going to go, wow, I got to start looking at everybody's throat and open and say, ah. And then you go, holy crap, I can't even see back there. Then you know you need to really open and really say, ah. And I'll say it with them even, let's go, ah, right? Especially the kids. I can't believe the size of tonsils and uvulas that I see since I started looking. That is probably the biggest indicator in kids, because removing the tonsils and adenoids is pretty much the first line of treatment for them, for their snoring and sleep apnea. So it's actually pretty important to try and take a look back there and get more comfortable with doing that. And you can tell your patients, I'm just checking to see how you're doing because I noticed your mouth breathing maybe. or I want to make sure that, you can ask them, how's the quality of your sleep? These are just simple questions that can be introduced slowly but surely. You're going to be uncomfortable the first couple of times, but maybe you were uncomfortable the first couple of times that you took someone's blood pressure. Maybe, screening for cancer is pretty normal. It's just something you got to get used to and you'll feel good about. And then when you find these things and help these people, you'll be motivated to do a lot more. The high palate as well is on that list that we just passed. And I'm not sure that I have a slide. I might have one coming up, but this is kind of my own little thing, the tonsils and tongues and tori, oh my. All this stuff is taking up space in the airway, right? This guy with his nose, he can't breathe through his nose because there's no room, right? So you bet he's a mouth breather and he needs help, right? If you have a tongue that is too big in that middle slide there, right? Like, where is the tonsils? Who knows, right? Look at the size of this uvula. Have you ever sucked a uvula up your suction? That's happened to me, right? These are tonsils. You shouldn't see those. They should be like, take a look up if you're not sure what normal tonsils should look like, right? And this tongue, it's totally stuck. It can't even go in the guy's mouth or the lady's mouth, right? So what's that happening again? Dropping back and causing probably snoring and sleep apnea, right? Anything that's crowding the back of the throat is going to be a problem. Right? Again, we've got tongues here. We got a high vaulted arch. That's a very narrow arch, right? But any kind of narrow arch. Your arch should be a nice big horseshoe, right? If you have crowding in the primary stage, you got to get on that right away. So that's an orthodontic type of thing, but I'm saying that shows that the bone's too small, right? So it's not a matter of crowded teeth anymore. It's like the crowded teeth are a sign that their jaw is too small. And that means that the bones haven't developed properly to be able to allow lots of air, like that hose, to come in. And what's more essential than breathing? I can't think of anything personally. So again, just to recap, right? And then we're going to go look at a couple other ideas. I did not intend for this to be incredibly short, but it's probably not going to be much longer because there's really not, I didn't want to complicate it. I want to keep everything very simple and just come out with, like, I know everybody's going, oh, is the ADA, which I think they have plans to come out with a specific list of things. But if you look up on the American Academy of Pediatricians, you'll see some very specific lists of things. And so that's what I'm trying to focus on, right? So they're looking for the retruded lower jaw. They're looking for the narrow jaws. They're looking for cross bites. And here you've got not just kids, again, you're talking about adults, right? Kids, sometimes they'll tell you, oh, the bruxing will stop. Will it? Are they having an airway issue? You need to know how to look and find out if they are, or send them to somebody who can look and find out if they are, right? The scalloped tongue, macroglossia is not actually as common as people like to think. This is probably more due to their mouth being too small. If you've got eroded enamel, you might have reflux. Again, that could be a sign that your airway's not working, right? So all of these things together, if you're overclosed, deep bites, right? All of these things together make your airway smaller, okay? So it's just an anatomical screening tool here. And it's really quite simple to be looking at all these things, but you do once you get it, right? It's not like you're going to go out, boom, I got it tomorrow morning and start screening. But definitely start screening, because if you don't, you're going to start breaking all your fabulous dentistry. Okay, this is also to show you that as you look down the throat, there's classifications for this stuff. So again, I dove deep into this because I was just fascinated, right? And I just kept going until I ended up, like I said, I'm going to do the board exam. So that's all I do, right? And this was a change over the past 4 years. The back of the throat is classified both by Mallampati and by tonsils. There's a number of different classifications for tonsils, but it's enough to say that 0 is no tonsils and 4 is like that picture where they're kissing. kissing tonsils, there's no air going back there. Okay. So those people really need a quick referral, and it's right in your chair and you could be looking. Otherwise, they can often be missed, right? And I regret, I wish I had learned this in dental school. And in fact, my son just graduated dental school about a year ago, right? And he's 27. He has sleep apnea. He also is not a big person. And he still has no clue about all this. He's still learning, okay? We together we'll get him doing better than having to wear a CPAP, but he didn't get more than maybe 3 hours of teaching about anything to do with breathing and sleep apnea in dental school. All right, so let's talk a little bit about tongue ties. That's my favorite subject, and that's what brought me here. So that's why I'm also bringing this in right now. So Dr. Zaghi runs the Breathe Institute. He's an ENT. His wife is a pediatric dentist. And I've taken their Breathe course, their tongue tie courses for infants. And the first course I took was actually Dr. Kotlow's course. And that's when I had my aha moment. So you can read all this. I don't plan on reading it through for you. I'm just going to describe to you how I understand it, where essentially if your tongue, so let's all sort of do that together. I don't know who's familiar or not familiar when, you know, you're breathing, hopefully all your mouths are closed, and then pay attention to where's the tip of your tongue. So if the tip of your tongue is behind your front teeth, awesome. If the roof of your mouth is in contact with all of your tongue there, even better. If it's not and it drops down like this, you probably have a tongue tie. So that's what set me off, because I had 5 kids. I was pregnant or nursing for 13 years. And I did all that because I was in dental school and I learned about craniofacial embryology. And I learned how nursing, because of the shape of the breast as opposed to a bottle, is going to help develop my baby's palate and mouth. Why didn't anybody ever mention that tongue does that too? The tongue does that too. I think that's where I just went, my mind was blown. And that's how I understand all of this. So you need to develop your palate. Your tongue is supposed to be up there. So if you do have a tongue tie and low posture, in other words, your tongue can't hit the roof of your mouth, you're not going to have a nice, big, proper, full development of your entire craniofacial structure here, right? So I don't like talking about orthodontics. I like talking about orthopedics, right? We're talking about craniofacial development. We can help people in ways that are so simple and so clear that it has been so life-changing to so many people. And we improve their quality of life as well as correct medical problems. So I would encourage you to look this up as well, right? For infants, I took Dr. Gahari's course. That was probably the best course I took online. If you're interested in treating babies, I would highly recommend his course. It was through the University of something or other, but anyway. Okay, so we're actually almost at the end. Why are we talking about grinding? Because basically it's, and I've put a lot of slides in here that show you who I'm learning from as well. So this is, there was one, I think, in there from, I hope from Dr. Lau was in there. I don't know if we missed that. I feel like we did. Anyway, he's another resource, Dr. Zaghi, Dr. Gahari. There's just, and these are ENTs. So again, all of these sleep doctors who are treating these people, well, they're not sleep doctors necessarily, but they're involved in that subject. And the sleep doctors themselves, like when I am taking the hundreds of hours from the AADSM, they're sleep doctors teaching. And it struck me how these are, so they're specialists, pretty much all of them. And then they go and do a year as a fellowship to do sleep. These are neurologists. These are ENTs. These are respirologists, pediatric respirologists. You know, they're like huge brain stuff, And then we just focus on this little part that they're interested in of sleep apnea. There are 80 sleep disorders. Sleep bruxism is actually one of them, but sleep apnea is what we're focused on, and they tend to go together, right? So when you're bruxing and clenching, there's some research now that is showing that actually it's your brain going, breathe, right? And so everything tenses up, so that like myofunctional therapy is, the idea is to create some tension in the oropharynx, right? When you have low tone and not enough muscles activated, that can also contribute to sleep apnea. And myofunctional therapy has also been shown to improve sleep apnea and reduce snoring. So this is part of the theory. I don't know if there's any specific studies out yet that have shown this as a way, but we definitely have a problem, because if you don't address this and they're going to grind and clench, you're going to break all your dentistry. So this is something, again, that's going to list all the things here. You've got the narrow upper palate, low tongue posture. So just a refresher. And again, not being able to breathe through the through your nose. Parasites is more of a Dr. Lin thing. It's he's into his diet stuff, but I still wanted to include this for the graphic here, right? And again, if you got more interested in this, there's lots and lots of information out there for you to learn more about. So again, I feel like, and in fact, an important part here that I wanted to mention was that if you just make a night guard for somebody, you could actually, and you don't look into whether they have sleep apnea, you could actually be worsening their sleep apnea. Just let that sit with you for a minute, because I know in my clinic, if anybody needs a night guard, they need to come see me until my team has got the nuts and bolts. Now they're fine, but until they had the nuts and bolts of this, I was like, book them with me just to take a look. And lo and behold, we would find this. They're also finding actually that the sleep appliances that we make are often helpful for people to grind less. So a night guard just kind of protects your teeth and your dentistry. The sleep appliance is, the theory is that it's deactivating and positioning the joint in a more comfortable position. And so people are grinding less. What do you do? What do you do? You find all these things. What do you do? Send them to their doctor for a sleep study. And then, as Renata was saying, you collaborate. There's so many. So the things that I do now are kind of on the left there. We also do frenectomies. I do work, I'm a myofunctional therapist myself. I work with one, though. I don't tend to do much of it on my own. And we do offer infant tongue tie release all the way through. My the other Dr. Silver is now going to be taking over the frenuloplasties, and he sutures them up. And so far the results are phenomenal. It's mind-blowing. Working with doctors here as well, which has been a new experience and really exciting, because they're really happy to have somebody else kind of helping with this and helping to manage their patients. I think that it's been a very rewarding experience to go through also the AADSM procedure. This has really been a very exciting time to be a dentist, to be honest, or be in the dental field. And I hope that was informative. I hope you take away from that some of the basic things to look for. And that's probably what I got for you. So if you have any questions, let me know.
Ta-da! Thank you so much. Let's see. Who is okay? All right, perfect. I'm just reading the messages from everybody. If anybody has any questions over here, let's take a look at the chat box, and then I have some other questions for you too. Oh, I did have a question as you were speaking. I was thinking about, oh, would you mind stop the share, please?
Sorry, yeah. How do I do that? Stop share. There you go.
Perfect. Awesome. Now we can see each other very well. My question is, what is the difference of a mouth guard and a appliance? Because in our world, we talk about all the time how mouth guards or night guards are just band-aids to an airway issue. And you mentioned sleep appliances actually reducing
Possibly.
clenching and grinding, possibly reducing grinding. How different are they?
So I think of mouth guards for like hockey, for sports mostly, and they're big, thick things. And I don't worry about those. Those are really to protect you from the puck flying or the ball flying or, that kind of issue. A night guard, I still make night guards. I have a lab here that does the nylon ones, so they're super thin. I use that also as a daytime orthotic at times, but for the most part, that's just in somebody who I have screened and we know there is no airway issues, and maybe we have an implant or two that just in case they ever do clench or grind, we've got them covered, right? But for the most part, we have to screen people. If they don't have an airway issue and it's clear, then go ahead and make your night guards. But if they do, you need to consider a referral to get a proper diagnosis or rule it out.
Very, very good. Yes, it did. As far as how they look, so if I'm a patient and I have something the dentist gave it to me, how do I know that it's a night guard versus a sleep appliance?
So a sleep appliance is going to be two appliances that are, I tell people we're making like two night guards, right? But it's going to hold your lower jaw forward, minuscule amount, right? So, and then people go like, how is that possible? How does it help me? Well, because when you pull your lower jaw forward a little bit, there's two reasons. One is because it opens the airway. If you're familiar with CPR, you've got head tilt, chin lift. That's going to open your airway, right? If you're familiar with what the surgical procedure is to treat sleep apnea, you're going to have your MMA surgery. That's going to pull everything forward, right? We're just trying to open the airway with these appliances. And you're talking about going from maybe, a 2 millimeter airway to like a 5 millimeter airway. So it not only pulls it forward, it actually opens it laterally as well because of this being a complex. And that was my kind of little point there, is that you can't just look at teeth. You can't just look at bones. You have to look at everything together with the muscles, which is why myofunctional therapy is essential.
Very, very good. Can you please, Kimi is asking, can you please share insight on how airway dentistry takes place in Canada? What types of trainings, organizations are present?
There aren't. What I think I'm like there's like a couple here, but they're I can't say they're even doing. It's still coming. We're still working on it. The West, Canada West is seems to be a little more forward thinking in terms of airway. I still get a lot of people going, "What are you doing, Simi?" So I think it's me who's like out here going, "Hey, man, let's talk airway," and try and teach them, because like I've suffered so much. Look at my 27-year-old kid who's got sleep apnea, right? He's a dentist. I'm like, how is that possible? He's had braces like 3 or 4 times. Thank God I didn't let them pull out any teeth. So that was my story, where I had 4 premolars pulled and I had the old-fashioned neck headgear. And so my whole family is far more like Bimax protrusive. And I just thought it didn't look good. So I wouldn't let them pull any teeth out. Plus, I went for a night guard 1 month after I had my braces off. So as a dentist, when I was in dental school, I just thought that wasn't right. And since then, I've always been on this quest to try and figure this joint thing out. Like, they don't teach you well at all. I ended up learning here with the Canadian Academy, like physicians. They were orthopedic, not surgeons, but medicine. So they do I've been doing Botox for years, and now I'll do prolotherapy or trigger point injections, things like that. They were using me as their test candidate, getting injections for carpal tunnel. I can't imagine going to a dental conference and working on each other's teeth, but that's what they do. So up here, there is where a lot of myofunctional therapy going on, but from hygienists, there is also Dr. Ramirez in Toronto, Dr. Joe Hall in Guelph, like they're running their own individual airway educational systems. I think it's a matter of comfort too, because the way you're gonna, like, it depends on what you want to do. What modality do you want to use, right? So for me, I gravitated to stuff that I'm already familiar with, and that's what I'm comfortable with, right? So it's basically an ortho evaluation. I get a Ceph. If I can, I get a CBCT. It's kind of tough up here. I don't want to order a CBCT in my own practice, so I have to send them out, and that's the whole
Oh, is that a Canada thing?
It's like a huge permit thing, and I just, yeah, I'm just not interested in starting with that. Like if I was doing tons of implants and all those things, then maybe, but at this point right now, I'm just not prepared to invest in the permit and the licensing and
Oh, okay, so you don't have a CBCT in your practice right now?
not in my practice, no.
Okay, good. Okay, making sure that like you were allowed to if you did have one.
If I don't, like I can get one if I want one. Yeah,
Yeah, but yeah, you don't have to. You can just send them somewhere else.
yeah, exactly.
And is
But I would
that
get them on
how do
every
you
patient.
determine? Perfect. How do you determine how much advancement to begin with when using an MAD appliance?
Go study with the AADSM. That would be my answer.
Well,
There's
she's
a lot of ways
speech
to determine
pathologist.
it, and the best way, initially you just titrate forward until the patient's kind of comfortable, but ideally you really have to go take another sleep study, right? So a home test or send them back for a PSG. That's the only way to really know if you have treated their apnea.
Very good. There are so many ways of titrating a mandibular advancement device. George Gage is one of them. We all
That's
know
not
that.
titrating. That's
Well,
taking measurement to begin with, right?
exactly.
Titrating is like it depends on also the appliance, right? Like if you're going to order the one that has the strap across it, the Avant, Somnobed Avant, right? You just change the strap out. Oh, I'm still snoring, or I'm still not sleeping well. Put on a new strap, right? If your jaw gets uncomfortable, go back a strap, right? So there's other ones that have little screws on them. There's other ones that you change the entire appliance. You get a whole series of the appliances. So I thought that was the question, like how do you titrate that way? The actual appliance.
How much do you start? Do you start with 1 millimeter? Do you start with 2 millimeters? That's what I meant. Like,
oh, how do you
there are
start?
so
Usually what I'm doing is a bit of I'm very functional oriented. So that's like your own comfort level, I think, is what goes into that, and your own sense of how much education you have around those issues. But essentially, like I'll have them as they're lying back, okay, snore for me, right? And if they can't snore as I'm titrating out, I know we're probably good.
Okay,
I
so
don't
that is
go past,
titrating.
like I don't start really far forward though. I'm usually starting at a pretty limited area, right? Not more than 50% usually if you're looking at numbers. I'm also sometimes checking articulation. There's so many different ways. I have like a bunch of different gauges in the office.
Perfect. Angela's saying, I noticed ENT may not refer for a sleep study, even if patients, even children, have a grade 3 tonsils.
Yeah.
Can we send patients straight for a polysomnogram? I can't say that word.
Yeah, a PSG. Yes and no. So it is a challenge here too. We have a shortage of doctors. So we've got some workarounds for that basically. And essentially, as far as the tonsils go, you have to look into your own, reach out to your local docs, reach out to the ENTs, see what you can do. See that I've been on the phone with the Children's Hospital here, seeing what I could do, how I could help. Calling, I send letters out and then wait to get a response and see what they say,
Yes.
right? If they say, leave me alone, I try another doctor. So that's.
Yes, just the fact that they have enlarged tonsils does not make them a qualified, to get a sleep study. Of course, you have to have symptoms. I think it was Dr. Tracy Wen that we interviewed, and she said that the size of the tonsils do not dictate the severity of the disease. So
no,
you
but
gotta
if
make
they're
sure that they have
snoring,
symptoms.
that's the
Look.
number one. Like, so if you look at the signs and symptoms, they have it printed somewhere here with the kids. That's a big one. The snoring is a big one, and removing the tonsils is the first line of treatment. So if they're having issues like that, they really, you really do need to try and find somebody who'll take it a little more seriously.
You gotta make sure they have symptoms. Dr. Paulo Suarez is saying, I'm working with lots of area focused dentists in Ontario. If anyone needs a recommendation, I'll be happy to share. If you guys have not watched, Paulo has spoken for us a couple times. He is absolutely fantastic. One of the best airway dentists I have ever interviewed. And he's doing a little special for us for Intro to Airway. So stay tuned. That's coming out soon. I think we're going to make it a special for members only. So
I'm
stay
honored
tuned.
that he's listening to little old me.
Danelle is saying, do the sleep appliances you prefer to use allow a lip seal? Do they also need a daytime appliance to allow the TMJ to adjust to the new posture?
So I don't have a specific appliance that I prefer. I try to customize it for whoever I'm treating. The lip seal, I will recommend either elastics or lip tape if necessary, but that's definitely a consideration, right? I'm a big fan of the thin little nylon ones. I'm not a fan of the EMA just because those elastics pop off all the time. But otherwise, I think any appliance that is going to be comfortable for that patient, you have to look at their occlusion and look at their jaw joint and just also know them, right? What are they going to wear or not wear? Some people hate having anything in their mouth. So you kind of have to feel all that stuff out and do your best to attain the lip seal for sure.
Very good. Angela's asking, you also can an RDH specialize or master in sleep similar to AA-DSM? I don't think so.
I'm sorry, I didn't hear the question.
If dental hygienists can specialize or do any type of extra
No,
training.
they have some team training though. They do have, take a look at their website.
Well, team training, they just can't get like specialized. You're not gonna get like you guys, if dentists become, qualified and then diplomat, but not dental hygienists. But yeah, just keep taking courses. We have a lot of sleep information in our Intro to Airway course, and stay tuned for more. Just in our webinars, we have had so many amazing people come talk about sleep. Join us to listen. And yes, Dr. Suarez, thank you so much for being here. It is such an honor to have you in the room tonight. Everybody's saying great presentation. Dr. Silver, thank you so much for coming to hang out with us in our Thursday Night Live. And before I go, I'm going to give you my spiel again from the beginning of our presentation. If you are a professional that is here on a Thursday night listening to all of us, please join our directory. It is free. Go to airwaycircle.com, click on directory, and click on add entry and sign up. You're going to have to create an account, add your training, add your information. If you have any recommendations for me to add to the directory, please let me know and I'll do it. It is easy to search for somebody, but we are having so many patients going to our directory daily looking for a professional that's close to them. So if you add your information there, I am sure you're going to start getting referrals. Amanda just commented over here saying that she joined the directory 2 months ago and she has gotten 4 new patients. Seriously. Patients know about it. They're looking for you. We just need your help, a few minutes of your time to help us, increase the size of this great resource that's the Airway Circle directory. So yes, congratulations, Amanda. And then of course, if you'd like to support what we're doing by raising awareness to the community, professionals and patients, please join our membership. It is $54 a month or $450 a year, and you get 4 webinars every month. Great community of professionals for you guys to collaborate and ask questions and share information. We would love to have you. Have a wonderful night. We're going to be back next week, and we have tons of courses and stuff coming up. Make sure you are in our Airway Circle professionals page on Facebook so you can stay up to date to whatever we have going on. But thank you so much. Have a wonderful night, everybody. Thank you, Dr. Silver. Mwah. Have a great night. Bye-bye.
Thank you, everybody. And thank you so much, Renata. It's a lot of fun.
Of course. Bye-bye. Say bye.